Thank you, Dr. Pernod. Thank you, Jonathan, for introduction, and welcome everyone. And I will try in 20 minutes to take us through the journey on a very complex 4 types of populations. So why are we talking about these populations together? Well, in reality, they all present unique HIV prevention, diagnostic, and care challenges. They have frequently been documented to have worse HIV disease outcome than overall populations living with HIV. They are physically, socially, and economically vulnerable populations, and they require tailored care and treatment approach. Very important that they are underrepresented in the majority of clinical trials and studies. And another important element, they are the ones who are driving HIV epidemic, and without addressing HIV treatment in these populations, we will not achieve our HIV epidemic targets. Let's start by focusing on women. I don't seem to move the slide. Let me try again. Here. Women comprise approximately half of the people living with HIV on the globe, and it's primarily driven by new infections among girls and young women aged 15 to 24 years who are twice as likely to be living with HIV compared to their male peers. About 5,000 young women get infected every week with HIV globally, and if we focus on Europe, women have comprised about 1/4 of new infections, as across all populations in Europe, migrants are the big contribution to this HIV epidemic in women. Women living with HIV usually have a lot of barriers to care. They have limited access, they're economically disadvantaged frequently, they frequently take care of multiple family members, they have particular issues of stigma and gender-based violence, in particular intimate partner violence, which is significantly more prevalent among women living with HIV, 55% compared to those living without HIV, only slightly over 1/3. They also have high rates of mental health and substance abuse, and they have another intricately connected epidemic of HPV, or human papillomavirus infection. In fact, women who have HPV infection are twice as likely to acquire HIV. At the same time, having HIV makes your HPV infection more persistent, and you are 6 times more likely to develop cervical cancer. Women with HIV, once acquiring the disease, have different patterns in several directions compared to males. They have different immune responses. Women, when presenting with HIV, usually have lower viral load and higher CD4 count than males. However, throughout the course of disease, the pattern of infection becomes more similar. We also know, if we look at the cohorts of elite controllers, we are seeing more women, and that suggests that more frequently demonstrate the phenotype of the viral control. Women have different body composition, drug metabolism, and elimination are different in women. We all know the differences in GEFR between male and females, and they also undergo significant physiological changes during pregnancy, for example, that affect pharmacodynamics and pharmacokinetics of antiretroviral drugs. Particularly in recent years, with a focus of INSTI-associated adverse events with a weight gain and BMI changes, we know that women behave different than men. On the right, you are seeing the data from African large cohorts of patients who switched to TLD, tenofovir, lamivudine, and dolutegravir regimen, and you can see big difference in BMI and weight changes between females and males. We also know that women, compared to men, have amplified risks of cardiovascular and cerebrovascular events. Potentially, it is linked to the levels of circulating markers of monocyte activations, which are different in women. And women face throughout the journey of living with HIV a lot of reproductive health issues, including prevention of mother-to-child transmission, but also some associated adverse events that can be further accelerated by HIV and antiretroviral therapy, like osteopenia associated with menopause. I will not dwell on it. There's an excellent review by Dr. Eileen Scully from the Johns Hopkins University that oversees potential mechanisms of those differences. But just to highlight their sex hormone-based effect, estrogen plays the role in acquisition of HIV. Estrogen also affects HIV transcription and in immune cell activation. There's completely different microbiome of women's vaginal tract and also of women's gut that can affect topical environment and can affect HIV-associated inflammation. There are really interesting studies that are ongoing looking at the X chromosome-associated difference in immune response regulations. And there are also immunological differences between men and women, and there is a clear relationship between residual virus activity and T-cell activation and different levels of innate cellular activation in women. Again, these are very complex issues, and I'm not going to deepen it, but we clearly have a lot of signals and potential mechanism of these differences. So wrapping up the topic on women, what I'd like to say is definitely women represent a complex combination of different parameters in anatomy, physiology, sex hormones, genetics, social, behavioral, and environmental factors that affect the outcome of HIV. We do know that in general, women have the same level of virological controls with the same antiretroviral therapy. However, we still don't know totally the subtle differences in residual immune activation and reconstitution and potential differences in the lifespan in regard of the aging and comorbidities. I haven't even dwelled in the reproductive health issues, but they're quite significant in women and affect the management and treatment. Our choice of ART, you have seen with dolutegavir's story, it can be very significantly affected by reproductive stage in a woman's life. And just to say, in the situation where we are looking at prevention of mother-to-child transmission, we have to focus not only on ART selection in terms of efficacy and safety on mother, but throughout breastfeeding as well, we have to consider infant. And we definitely need more research to understand those differences. Well, let's switch gears and move on in adolescent population, someone that I serve in my clinic daily. Adolescents comprise about 2 million people living globally with HIV, about 5% of all people. We've done a really good job. If you look in the last decade, there's been a 46% decrease in new adolescent cases. However, they still comprise 11% of the new cases globally. And it's primarily adolescents from East and Southern Africa and West and Central Africa, young females, 15 to 24 years of age, who drive this epidemic. However, Eastern Europe and Central Asia are number 3, if you look at the yellow and blue bars on your right. Adolescents all have suboptimal coverage with treatment globally. Only 59% of those young people are actually receiving treatment. And if you look at the rates of the coverage, they're quite different and can be as low as 42% in some regions of the world. The viral suppression adolescents is usually suboptimal compared to general population, can be as low as 27% to 89%. And even in my US clinic in Washington, DC, where I have all the possible drugs, tremendous amount of case management and other ancillary services, viral suppression rates with all modern therapies are only 72%. And we also know that in adolescents, year 1 to 3 after start of treatment, viral suppression continues to decline. Adolescents face multiple challenges, and on the right you see cross-cutting challenges that affect horizontally and vertically infected adolescents. They have limited independence. They have multiple adherence barriers. The relevance of long-term consequences of disease is very hard to perceive at this age. This is a time of risk-taking behavior and sexual onset. This is a time of disclosing and stigma that can be more vulnerable compared to adult and well-established population. Multiple mental health issues. If you look on the right of your slide, I highlighted specific challenges that can be seen in perinatally infected adolescents. This can be growth and maturation delay, particularly in those who have been diagnosed late. Many have lost their parents and primary caregiver, have been placed in foster care and care of older people. They get very tired of taking medications throughout all their life, and those of us who take care of them know you can have perfect viral control over the lifespan of the child. They hit adolescence and the viral suppression is gone, and you start seeing very high viral loads. So this is a very common pattern. And across all populations and all continents, poverty, lack of social protection, and violence have been a really strong barriers for adolescents to access care. Generally, when we design adolescent programs, we try to develop patient-focused approach. We need to support their independence with transportation, housing, employment, and food security. We need to continuously work on self-management skills. This is a time of transition to being responsible for your own health. Peer involvement plays absolutely a key role in supporting adolescents. We will never deliver the support and messages to them if they don't hear the same from the people relevant to their age and environment. and meaningful engaging of them in designing the services for them is also crucially important. Finally, you cannot provide services to adolescents without assuring mental health screening and support and exploring novel antiretroviral approaches. And I wanted to share with you the experience of rolling out an injectable cabotegravir-rilpivirine program in my program in Washington, D.C. We started it in the fall of 2021. In March 2022, we expanded it following the FDA approval to those aged 12 years and older with a weight of 35 kilograms. Obviously, right now it is primarily for virally suppressed that we are giving it. And you can see here pictures of my young patients who have traded the pills they are holding to monthly injections of cabotegravir-rilpivirine. You can see here the numbers. Our clinic has been growing, injection clinic, and it's not without hiccups. There are some issues there. We have seen breakthrough transient viremia. We haven't had any resistance, but it is nevertheless a modality that seems to attract more and more interest in young people. And I just wanted to highlight to you, there's a LATE protocol that started enrollment in September of the last year that's looking at non-inferiority comparison to oral TLD, and there is also IMPACT trial that is ongoing with full recruitment completed, and that is a trial that contributed to FDA approval of the lower weight and age band, and we are going to hear more results on the longer-term efficacy from this trial soon. Let's go ahead and switch gears and move on transgender populations. I was surprised preparing for this talk how little epidemiological data are available and how outdated it is. The latest that I found on UNAIDS that people who are transgender are 14 times more likely to be HIV positive, and the majority of the data that I could find are on transgender women. On transgender male, the prevalence of HIV is estimated between 0 to 10%, and the latest number I've seen is at 2.5%. Transgender women, however, a significant proportion of those living with HIV in Asia Pacific and all over the globe. And if you look at the prevalence of HIV among transgender women, it's very high. You can see it ranges from 13.5% in Western and Central Africa, all the way to 28 and 4% in Eastern and Southern Africa. And I've tried to pull some European data at the bottom of the slide. In Italy, I could find prevalence of 12% in transitioning male to female, and you can see prevalence in Netherlands and Portugal among transgender sex workers. In Washington, D.C., where I work, 1 in 3 transgender people is living with HIV. And importantly, 19% of them say that even without generally welcoming environment for gender-affirming therapy, they still have had a hard time accessing HIV care because of the change of the gender. Transgender people face multiple challenges to accessing the care. There are very high rates of transphobia and criminalization. There's frequently abuse of substance. They face unemployment, lack of female support, violence, discrimination. Transgender women in particular are less likely than cisgender men to have control of the HIV with the same therapy. They are mostly likely to be adherent. And when you look at the population themselves, even when therapy is prescribed and there is access to care, they frequently have a lot of concerns about drug-drug interactions and might not be taking medication, so require enhanced adherence support. Looking at the drug-drug interactions with gender-affirming hormones is a really important task when taking care of the transgender person. And I want to highlight here that all of the studies on drug-drug interactions are derived in cisgender women with the use of contraceptives. We really don't have the data on the estrogens that are used in the gender-affirming therapy, which is 17-beta-estradiol, compared to the atenyl estradiol, which is an oral contraceptives. Nevertheless, in United States guidelines, and you have seen the table, we have come up with a table that guides your selection of the drugs with gender-affirming therapy. That's excellent source of reference, but we definitely need more data because the hormones might not behave exactly the same way interacting with antiretroviral therapy. It's very important also to remember that laboratory values are not the same in people who have gonadectomy and on gender-affirming hormones. And it's really important to look at the data. Again, here we still lack data. We definitely need more research. We don't have normal values established, but general rule is if you didn't have gonadectomy and you are not on a hormone replacement therapy, we are using your birth gender to use normal values reference. However, if you had gonadectomy and you had your hormone hormonal therapy, we're using the new affirmed gender as your relevance. And for some values, it's particularly important, for example, for estimating EGFR with a larger muscular mass on hormone affirming therapy, hormonal therapy, it's very important to use different measurement of EGFR, such as cystatin C-based EGFR reference. So in general, when caring for the transgender people, it's really important to create non-discriminatory, non-judgmental, culturally appropriate, sensitive care. You cannot care for them without addressing mental health and substance abuse. The providers that care for people who are transgender need to be at least familiar with gender-affirming therapy principles and non-medical and surgical gender-affirming interventions. It's very important to reference for drug-drug interactions, not only with gender-affirming hormonal therapy, but also with psychotropic drugs. And it's very important to recognize that we start seeing more and more data that transgender people face a lot of comorbidities, such as hyperlipidemia, elevated cardiovascular risk, osteopenia, and those are comorbidities we're also seeing with HIV. So early screening and prevention are crucially important. And finally, paying attention to the laboratory values, as I highlighted. And final population that I will address in my talk today are aging people with HIV. The number of people older than 50 years of age with HIV is growing globally and has reached over 8 million in 2020. The problem with aging people is that they present, when diagnosed newly, they present late. And they present late across all the globe. On the left, you see some very excellent analysis published in Lancet HIV last year, shows 60% over age of 50, 63% of late diagnosis compared to 42% in England. And across all other settings, there are multiple international settings analyzed there, 34% versus 20%. They usually also present with much lower CD4 cell count. And the problem with late diagnosis with aging people that a lot of the early symptoms and signs are attributed to the aging and might be misinterpreted and not be taken care from the point of view of HIV lens. And equally, a lot of providers don't consider this population sexually active and don't consider them to be at risk. So very few studies there. We know that aging people with HIV face multiple comorbidities. You see these multiple bar graphs with the blue and red. These are major cardiovascular, cerebrovascular diseases, renal diseases, cancer, and osteopenia, and osteoporosis. And you can see that in every modality, the red bar is higher than the blue bar, people living without HIV. And there are several major drivers of these high rates of comorbidities. Those include chronic immune activation, even with a successful antiretroviral therapy, ART toxic effects, co-infections, multiple disparities in healthcare, harmful lifestyle, and accelerated aging. And we do recognize today that people living with HIV have accelerated aging. There are some really excellent study and analysis with this graph that is, to me, was one of the most demonstrative, looking at whether ART can slow this accelerated aging. But even in the brain autopsy studies, we know that the brain in people living with HIV is advanced in age by 7 years compared to chronological age. And there are some really cool studies modeling by machine learning algorithm what could be the potential risk factors that accelerate the aging. And in one of the studies, cardiovascular risk score being high, detectable viral load, and being co-infected with hepatitis C seem to be major drivers of premature aging, as well as socioeconomic disadvantage and unemployment. There is another big issue that with people living with HIV who are aging is polypharmacy. And instead of dwelling on it, I pulled one study, which is one of the largest studies published to date from the veterans aging cohort in the US. It's primarily male cohort, and it's quite significant older, 64, almost 65% are 50 to 64 years of age. They looked at over 9,000 people living with HIV and compared them to almost 38,000 of veterans who do not have HIV, and for each additional medication, people aging with HIV had significantly more drug-drug interactions, and adjusting for non-ART drug-drug interactions, each additional medication brought them increased excess risk in hospitalization. And actually, the authors of the paper proposed several strategies in reconciling medications, completing list, considering non-pharmacological treatments when feasible, selecting non-ART medications to minimize polypharmacy and associated drug reaction, and using electronic decision medical tools where applicable to alarm the physicians of the polypharmacy issues and to try to diminish the number of pharmaceutical agents that are used by older people. So in summary, with elder populations, with aging population, we need to work on avoiding the late diagnosis, which currently is quite excessive. We need to really try to mitigate polypharmacy and assure frequent drug reconciliation. And we need to promote healthy aging and address preventable comorbidities. I frequently will tell my adolescents, I want you to start thinking about your cholesterol today when you are 19 or 20 years of age. We do know there are several drivers that serve as a geroprotector, such as physiological reserve, intrinsic capacity, and resilience, mental resilience, spiritual resilience can help as well, and we need to explore their role. So in summary, women, transgender, adolescent, and aging people with HIV all, and I hope I have proven to you a little bit today, diverse biological and social factors affecting the HIV care and treatment, and we need to recognize them, and we need to tailor our health services to these populations. And there is definitely continued need for research. A lot of what I have shown you today are speculations and early pilot data, and we definitely need to very actively enroll these populations in HIV-related research. I'll stop here. Thanks.